Dear Professor Tripathi, thank you very much for inviting me to the first international conference on dental sleep medicine. I'm honored to have the opportunity to present my therapy concept, which I have developed over my 25 years of practice in this field. Now, having been given the chance to present my work to such a renowned and international group of speakers fills me with pride. My therapy concept is based on the idea of using three highly precise aids that exhibit very little redundancies. The combination of these aids yields a significant increase in quality, effectiveness, and efficiency of the entire treatment process. The aids I'm referencing here can be split into three separate solutions. First, the vector diagram as a framework. Second, the GS gauge as an instrument. And thirdly, the FUPS as MAD. In our clinic, the combination of these aids has significantly reduced laboratory treatment times and increased our patients' satisfaction. Both at the beginning and throughout the MAD therapy, it is critical to measure specific indicators to help guide decision making. Thus, we can effectively weigh risk and opportunities of the MAD therapy against one another and craft an effective treatment plan. A comprehensive and tailored risk profiling is a visible solution here in creating a framework to standardize this process of identifying these so-called predictors can greatly increase efficiency. Said framework can be seen here in the form of a vector diagram, which allows us to visually compose a risk profile for each patient. This visual representation further allows for a swift comparison between consecutive risk assessments to allow for the evaluation of progress throughout the treatment. The predictor value are segmented into three risk groups and colored-coded via traffic light system. Utilizing this visual aid allows a quicker assessment that can be intuitively grasped by both the practitioner and the patient. This not only facilitates the interdisciplinary decision-making between the dentist and sleep specialist, but also aids the dentist with educating the patient, thus also informing the patient's decision-making process. Moreover, the vector diagram helps guide the therapeutic decision-making throughout the entire MLD therapy. Therefore, the framework helps to both optimizing the starting conditions for the MAD therapy and reduce the risk throughout the therapy. However, this diagram is not intended for the precise recording of all dental parameters, nor shall it be used to assess the quality of oral health overall. The diagram's intention is to primarily increase the quality, effectiveness, and efficiency of the therapeutic decision-making process for MAD. Above all, it aims to lay the foundation for treating large patient populations and thus making it a viable tool for the use with public health insurance providers. The risk assessment covered by the vector diagram spans the three areas of biological, mechanical, and functional values of the stomatogenic system. The biological area relates to periodontics, the mechanical area to prosthetics, and the functional one to the function. The vectors and the labeling of these three areas are shown with different color light blue, dark blue, and black for better visual differentiation. Here you can see the biological findings in light blue. The collector values are marked in the diagram, in this instance the BOP, either with its value in the given selection here, or scaled on the vector array. This makes it easier to identify minor changes during a follow-up. The line connection results in the individual biological risk profile for the MAD therapy. As you can see here, the mechanical relevant findings for tooth loosening, the number of teeth, and the profile of the support according to the Eichner classification are also collected. The Eichner classification is basically only a classification of the gap dentition according to the profile of the dental support zones intended for prosthetic therapy. However, this classification is not sufficient here for the risk analysis in MAD therapy. In the vector diagram, this classification is therefore further subdivided into a dental and an implantological support zone profile without prosthetic gap closure, as well as the occlusal support zone profile at the time of the examination, possibly with prosthetic gap closure. The dental classification is marked without, while the occlusal classification is marked with an asterisk in the vector diagram. To further illustrate this, here you can see the dental classification without prosthetic gap closure. Here, circled in red in the picture, the Eichner class B1 from our example of the gap profile with dental support in 3 of 4 support zones with 3 missing teeth. And here you can see the classification at the time of the investigation. After bridges have closed the gap, the result is an occlusal Eichner class A after bridge restoration, here circled in red. From this vector profile, it can be seen in which risk area, for example, the dental support is in relation to the occlusal retention of the MAD. Throughout the course of the treatment, the vector diagram thus reveals occlusal changes as possible side effects of the MAD therapy. Finally, the 3 relevant function findings, which include active degree of protrusion, active degree of mouth opening, and the graded chronic facial pain after DCTMD, need to be assessed. The active degree of protrusion is measured from the maximum retrusion into the maximum protrusion in the lying position after 3 attempts. In my opinion, and in the opinion of many other colleagues, this is the most precise measurement method. Only values that can be achieved without locking of the jaw or pain are measured. The same procedure is used to measure the active mouth opening. Finally, the GCPS grade is entered from the assessment of the corresponding questionnaire according to DCTMD, which completes the creation of the risk profile for the function. Here you can see an example of a fully completed primary assessment. Based on this assessment, we started a combined periodontical and prosthetic therapy before fitting the MAD. The changes after this therapy are marked in blue. There was a lowering of the biological risk profile over the BOP and the pocket depths, and a lowering of the mechanical risk factor over the increased occlusal support zones. As a result, the GCPS functional risk profile was reduced. Now, after 2 years of treatment with MAD, there was a slight increase in GCPS as the patient may have meanwhile neglected the daily jaw exercise, here marked in black. Upon highlighting this to the patient and nudging him to resume the exercises, we could expect GCPS value to improve as such. Once the decision for or against MAD therapy and for or against preparatory measures has been made and these have been completed, the second most important treatment step follows: the adjustment and the registration of the starting position, which is critical to produce the MAD. From July 31, 2021 onward, the MAD therapy will be covered by the public health insurance in Germany, and the requirements to receive the needed coverage includes an individual three-dimensional registration of the starting position. This registration must be tailored to the individual circumstances of the patient as well as to the individual design of the MAD that is to be used. Bite forks are used as aids for this. They offer the advantage of flexible adjustments under functional neuromuscular conditions when compared to the use of no bite forks or the axiographies. All bite forks currently on the market neither fully nor ideally meet these requirements. Bite forks, which are held between the rows of teeth by the patients biting down, are subject to variability during adjustment and registration, which reduce precision. Here you can see an example of how, during the positioning of the bite fork, the occlusion changes due to the different muscular activity of the patient without changing the adjustment of the bite fork. The precision can be increased considerably by securely fixing the bite fork to the upper jaw. The bite spoon is fixed to the upper jaw with A-silicon, and the lower jaw is supported by means of a supported pin registry. This allows for a more comfort due to the relaxed jaw, interference-free adjustment and registration in the lying treatment position without a forced bite. The GS gauge consists of a bite spoon in yellow, the vertical bar here in turquoise, and the horizontal bar marked in blue, as well as two fixing screws colored gray. A standout feature of the GS gauge is that it can be continuously adjusted in all three spatial dimensions, sagittally, vertically, and transversely. The support of the horizontal pin on the tooth edges of the mandibular incisor, here circled in red, can be continuously adapted for a safe adjustment of the mandible on the GS gauge, here marked with arrows. Now I would like you to show a video about the assembling of the device. Here you can see the box of the GS gauge in white. Inside you see the blue tray with the 5 elements of the GS gauge. Remove the bite spoon, insert the vertical pin, insert the screw at the top to fix the vertical pin. That's the horizontal pin, and insert the screw at the bottom to fix the horizontal pin. Now the GS gauge is ready to use. Move the horizontal pin for sagittal adjustment and for optimal support on the incisor edges of the mandible. Move the vertical pin for vertical and transversal adjustment. The adjustment and the registration range extended sagittally from 20 mm behind and up to 16 mm in front of the upper edge of the incisor. A vertical bite lock can be set from 1.5 mm to 14 mm. The red rectangle marks the adjustment range of the GS gauge in the Poisson diagram. This shows that the GS gauge is also used in extreme anatomical variants such as strong progeny or retrogony, as well as in the case of a strongly pronounced frontal open bite, and is suitable for the F different variants of the protrusion trajectories and characteristics of the spay curve. As the three-dimensional adjustment must be coordinated with the design of the MAD, this further emphasizes the practicability of the GS gauge. Transversally, the GS gauge allows an adjustment of 15 mm from the center line. This transversal adjustment should also be adjusted habitually in a lying position without functional symptoms occurring. We want the patient to be as relaxed as possible. The three-dimensional adjustment is completed if no pathological functional findings occur and the patient does not complain about discomfort within 5 to 10 minutes. Now I would like you to show a second video about the adjustment and registration with the GS gauge. First, application of A-silicone on both wings of the GS gauge. Symmetrical insertion of the GS gauge on the maxilla. Fill in 1 or 2 strokes of A-silicone and wait for harden. After that, the GS gauge is ready to use. So marking the 0 position of the IID, first green marking, then the working position with the GS gauge, let the patient bite into the hollow, and if necessary, reline the horizontal pin for this. Control the bite blocking, and then transversal starting position, blue mark. Vertical start position, second green marking. And if necessary, enlarge the bite block. Control the blockage. And make the third green mark at this position. Now sagittal adjustment. First red marks in maximal active reduction, second red mark in maximal active protrusion, and the third red marks in the starting position. And leave the patient in this position for 5 to 10 minutes. It's very important to have no functional discomfort. Otherwise, you must do this procedure again. So first frontal encryption with the silicone and wait it for harden. And then encryption in the lateral side, or on the right side you see the registration, the digital registration. So after that, the registration is complete. This is the fully registration. On the left side, analog, on the right side, digital. After the use, the GS gauge is reprocessed with the help of the tray, here in blue in the picture, and the box. Most importantly, the reprocessing meets the requirement of the MDR in all stages. On the left side, you see the GS gauge in the thermodisinfection, and on the right side, the GS gauge is ready for sterilization. We now come to the third part of the series of aids, the MAD, and we will highlight how the adjustment with the bite fork should be tailored to the individual patient situation and the design of the MAD. The puzzle diagram shows here that with increasing bite blockage with the same protrusion, which can be measured in relation to the upper jaw, the load on the craniomandibular system increases. The tension vectors are marked here with dashed lines. We can gather from this that the percentage of the same protrusion in relation to the maximum protrusion increases with increasing bite blockage. Here the lower jaw incision point can be seen in the same cranial position, which, however, makes up approximately 50% of the maximum protrusion in 3 mm bite blockage, whereas in our example it is approximately 70% protrusion with 10 mm bite blockage. In this respect, registration should be carried out with a little bite blockage as the bite condition and the MAD design allows. The protrusion should be adjusted from the maximum retrusion to approximately 5 mm in the comfort zone of the patient. I have already referred to the 5 to 10 minutes control of this position with regard to the functional findings and the comfort findings of the patients. From this starting position, sleep medical titration continues after the MAD has been inserted. In order to be able to achieve the lowest possible bite blockage, especially in patients with a deep bite or a flat speak curve, I developed a MAD as early as 2003 that enables this. This leaves the front teeth mostly free. This makes the plastic construction more unstable, yet this instability is absorbed by a steel arch to which the Herbst hinges are attached by laser welding. Here you see the two designs. Hubs 2003 started with analog manufacturing, and the design beginning with 2018 in CAD/CAM manufacturing. Although this construction has many advantages, the disadvantage is the mechanics of the Herbst hinges. As every time the patient opens his mouth during the night, a retrusion occurs. Frontal elastic bands are intended to prevent this, but unfortunately cannot do so completely. If the Herbst telescope is mounted on the MAD in reverse, unphysiological stress arises on both the MAD and the dental arch as well, as on the craniomandibular system when the mouth is opened. Therefore, no desired physiological conditions can be achieved. Inclined planes attached to the side also do not allow a physiological opening of the mouth and do not reliably prevent an opening of the mouth. Frontal elastics are also required here. As we can see, all these approaches are at least somewhat flawed. In my opinion, the solution lies in the fin-like design of the lateral guide elements. With these, it is possible for jaw opening to physiologically occur during the night. These openings occur typically with 5 to 10 mm IID without retrusion, which constitutes a physical adjustment of the MAD without any loss of effectiveness. Above, you can see the situation in the starting position, and below, the moving opening with 2 mm protrusion and 3 mm bite opening. This is followed by a guided jaw opening with a slight retrusion, but without coming from the starting position behind the protrusion. Up to 10 mm IID, there is therefore no absolute retrusion compared to the starting position. Here you can see the guided jaw opening of the model from the starting position in the video. And here on the patient himself. It is also important that there is no lifting of the MAD from the rows of the teeth. The guided jaw opening is divided into 3 parts. From the starting position, the first part starts with the jaw opening with a protrusion movement of up to 5 mm IID. The protrusion is intended to reflexively prevent the number of further jaw openings with a larger IID during sleep. If there is still another jaw opening, the second part of the movement follows with a jaw opening with unchanged protrusion up to 10 mm IID. Only from 10 mm IID, which normally does not occur during sleep, is 30 the further jaw opening with retrusion up to the disconnection of the 2 splints parts at 20 mm with releasing for maximum jaw opening. The fin of the FUPS are not made separately. In this design, the upper and lower jaw splints are CAD designed and milled from a single block. This is the only way to produce the FUPS with this fin design for an optimized function without retrusion and with the ideal recess in the anterior tooth area for the last possible bite blockage with very high stability here circled in red. Optionally, this sagittal guideway can be made more precise from the starting position by a further registration in 10 mm IID. This is recommended if the jaw opening path shows lateral deviation, as this video shows. The first registration takes place from the starting position at x1, the second at 10 mm IID at x2, in order to be able to shape the guideways transversely. For this purpose, after the first registration of the starting position, the sagittal, vertical and transversal setting values are adopted from the GS gauge. The IID setting is increased to 10 mm and readjusted if necessary, according to functional aspects. First, the frontal coating and waited for harden. And second, the lateral coating, and waited for it to harden. After frontal and lateral coating with silicone, the GS gauge is removed. Here you can see the registration in the starting position on the left side and the frontal and the two lateral registration at 10 millimeters IID on the right side. This procedure is possible because the jaw relation can be transferred from a first registration to the second registration by adopting the three-dimensional setting values of the GS gauge. It is therefore not necessary to keep registration for later new MAD productions. Acknowledgement of the three-dimensional setting values of the GS gauge is sufficient for this. That brings me to the end of my lecture. In summary, I can say that during the development of these three aids, the treatment of my patients has steadily improved, and due to the use of these aids in conjunction with each other, the treatment quality has improved yet again. Thank you for your attention, and I hope that you found my presentation informative and above all thought-provoking. I look forward to hearing your thoughts and feedback. Thank you for your time and many greetings from Hamburg to Lucknow.